Thank you, Ken, and thanks to Jeff and the organizers. I'm really thrilled and honored to be invited here today. It's probably about a year ago, maybe a year and a half ago, that I was speaking with Jeff, and Jeff said, I have this idea. I'm thinking about having a conference at Ohio State. Would you come? I said, absolutely. What he also told me was it was going to be a small meeting. I swear. He said, man, like a little think tank small meeting. Interesting. So again, really thrilled to be here. I'm going to give you in 30 minutes, actually 29 and a half minutes, a sort of brief overview of a very exciting aspect of what we do for ketogenic diets, which is treating epilepsy. It's got a long history, a very interesting history, and that's what I'm going to try to give you, sort of an overview, touch base very briefly on a few hot topics, and then we'll have time for questions, and then during the lunch break, I'm glad to chat with anyone else who wants to talk about it. I think we're all having a little trouble with this. How hard do you hold? There we go. Okay. In terms of my disclosures, these are some of the groups that I help with the advisory boards for and some royalties that I'm also involved with as well. One of my absolute favorite advisory boards that I've been part of for now about 10 years is actually Atkins Nutritionals. Many of the experts here today, Jeff and others, are on this medical advisory board with me as well. There are sometimes I wonder why I'm still part of the board. As a neurologist, I think I bring a different perspective to sort of the use of ketogenic diets for all kinds of conditions. But I think maybe one of the major reasons that I'm part of the board still today is I have somewhat of a larger historical view. And I think we heard from Jay yesterday, he mentioned the idea of a tipping point, that maybe here today this is a prime example of how we're at the tipping point of using ketogenic diets. In the epilepsy world, we're past that. We're actually beyond the tipping point. And so I'm going to give you a little bit of a tidbit maybe of where things could go in the future. It's exciting and kind of cool, where the diet for epilepsy is mainstream. It is everywhere. And so what happens when that happens maybe for your world? I'd like to think that this is exciting. And thank you. That explains it. Okay. You heard from Colin. He showed you a nice image from 1919, I think it was, 1930. I'll go a little further back to zero. So we go really far back in the use and the concept of fasting and dietary manipulation for epilepsy, even before they even knew what epilepsy was. This is a reference in the Bible of what appears to have been an adult patient who had childhood onset epilepsy, continued to have seizures. They brought him to Jesus, and what Jesus recommended was prayer and fasting. They knew it worked. For a long time they knew it worked, and actually they didn't know why. And so in 1921, some really smart researchers said, hey, maybe we can come up with something that's sustainable. We can do fasting for long periods of time. We know that's possible. But is there something we could do for months to perhaps even years as a treatment for patients with epilepsy? And so we're approaching now the 100-year anniversary, about 3 years away. July 1921 was the first article published on the ketogenic diet for epilepsy, back from the Mayo Clinic, where they decided to try a high-fat, low-carbohydrate diet and see if this would, at least at the time, mimic the effects of starvation, mimic fasting. And actually, still even today, you see in chapters and reviews, they'll say things like the diet was created to mimic starvation. True, but we actually know now on a scientific level, they're probably two completely separate therapies. We know the diet works, interestingly, in some animal data and a little bit of human data, that fasting works by a completely separate mechanism to help suppress seizures. But again, this was back in 1921. That's why it was created, still generally in very widespread use today for epilepsy. Things have changed, though. For a while, it was extremely popular. There were very few drugs out on the market. And then in the 1940s, 1950s, we reached our what we call second generation of anti-epileptic drugs. We are now in the third generation. You can see sort of an escalating number of drugs coming out on the market. I don't think this necessarily caused the decline of the diet, but it certainly gave patients other options, and so they started using some of these other options. And for many of them, these are very successful. Most patients, about 75% of patients worldwide with epilepsy, are easily controlled with very low side effects on medications. They can keep things private. They can do whatever they want with their diet and go about their business. But again, lots of different drugs out there, so lots of other options for our families. And as drugs came on the market, we certainly, around that time, saw the decline of the diet in terms of common use around the world. We're still seeing that somewhat today, and I'll show you kind of where we are 2018. We certainly do have our challenges. Families see all of these medications out there. Researchers are trying them. The biggest challenge today, any of you familiar with Epilepsy World? Medical marijuana. So we actually just had the first medical marijuana pharmaceutical agent approved by the FDA a few weeks ago, probably going to come out in a few months, called cannabidiol, or Epidiolex is the trade name for it. Probably the biggest obstacle, at least to me in my ketogenic diet practice, patients want to try cannabidiol instead. I say, you can try it and then come back to me when it doesn't work. In the early 1990s, we were not in a good place. As these drugs were coming out on the market, you really had to struggle to find ketogenic diet centers. There were a few of them in the US, a scattering around the world, but not many. And it was generally used only after multiple medications had failed. If you went to the American Epilepsy Society meeting, good luck trying to find anything on the ketogenic diet. The first poster was actually 1995, first poster on the ketogenic diet at the AES meeting. And it was really kind of perceived and written about in chapters and reviews as an alternative therapy. And sort of we've really come a long way in telling patients this is a non-pharmacologic therapy, not an alternative therapy per se. The Charlie Foundation is really one of the biggest factors in sort of changing the mindset, and maybe will be true today in sort of metabolic disease, diabetes, and cancer, is what a parent support group really can do for changing public mindset. Pretty amazing. The Charlie Foundation in 1993 was sort of born from the experiences of a father of a child with epilepsy, and who really wanted to get the word out and really get research out that this was, again, an established therapy at the time. It had been an established therapy for 75 years, yet really wasn't being widely used. And so the Charlie Foundation in 1993 really changed the whole landscape of my world of ketogenic diets for epilepsy. There are lots of books out there. I know there's some out in the hallways. These are just devoted specifically, for the most part, to neurology, epilepsy, using recipe books for specifically patients with epilepsy, as you can see in many different languages. We'll come back to some of the international use a little bit later. There's been an explosion of research, true for your field, true for mine. We've gone from now a paper every month to now about a paper a day. I just checked this morning. There were 2 more papers, including one was actually an RCT for Parkinson's that I have to read on the plane. Incredible, hard to keep up with all of the field. For a long time, one of the big arguments that would come up usually at the American Epilepsy Society meeting was they say, yeah, that's great, Eric. These are single center, often retrospective case series of ketogenic diets for epilepsy. We need randomized controlled trials. They're done. Okay, so we actually now have 7 randomized controlled trials, both pediatrics and adults, all different variants of the diet, all showing good benefit. The argument that existed for a long while that would say, well, do these really work, is over. Okay, you really don't even hear that anymore at any of the Epilepsy Society meetings. There's no discussion that maybe diets should be studied more in randomized controlled trials. Again, the tipping point has passed. We're now doing more interesting sort of studies. This is from the Cochrane Review. These are one of these reviews where they look at all of the literature to date. Back in 2012, they came out with a statement in one of their reviews looking specifically at ketogenic diets for epilepsy. And they said, quote, these studies suggest that in children, the ketogenic diet results in short to medium-term benefits in seizure control. There's still some work to be done in long-term benefits, but granted, that's an excellent comment, the effects of which are comparable to modern anti-epileptic drugs. We actually didn't think they were going to say that in their review. So we have this out there when insurance companies or certainly certain governing bodies say, well, is there evidence the diet works? We give them this Cochrane review. The discussion, the argument ends very quickly. August, where are we today? It is actually now just certainly widespread beyond the United States borders. Multiple countries doing ketogenic diets. Some are actually involved in multi-center national guidelines that are out there. As you can see, and I'll come back to it, there are certainly areas, more the lightly shaded gray, that we have some work to do, and I'll wrap up at the end with what we're doing to try to help some parts of the world that don't have ketogenic therapies for epilepsy. And now today, again, it's a very different world than when I started my fellowship. We still typically use the ketogenic diet after 2 drugs have failed because for the most part, again, drugs do work with relatively low side effects. Most pediatric epilepsy centers have a ketogenic diet center. I have competition. It's the reality of what things are, and it's good for patients, but it is tough sometimes for recruiting for trials. Nationwide Children's, only a couple miles away, has actually a very good ketogenic diet center. They're everywhere. It's actually for pediatrics, and that's why I underlined it. For adults, not so much yet, but it's changing. It is one of the 4 major therapies we use for epilepsy. So we use medications, we use electrical stimulation or vagus nerve stimulation, we do epilepsy surgery, and we do dietary therapy. And most chapters, reviews, articles will list those as the key 4 therapies out there for epilepsy. Very, very cool. And it is actually getting easier and easier nowadays for families to be convinced. I think a lot of that has to do with all of you in the room, and sort of the low-carb ketogenic movement has really changed the landscape of what parents are perceiving. And more now I have families come in where the child has epilepsy, they're thinking about dietary therapy, and the mom and the dad say, oh, we're on it ourselves. I say, great. It'll actually make things easier around the house, and it's not as much of a difficult discussion to have about starting the ketogenic diet. We are in an exciting year. It's actually the 25th anniversary of the Charlie Foundation, and it's really, again, changed the landscape of what we do. We are about to have our 6th biannual ketogenic diet conference, again, focused on neurology. It's going to be held on the island of Jeju off South Korea, a little bit harder to get to maybe than Columbus. It's coming up in a couple months. We're actually really excited about that. There have been ketogenic trainings with very creative names, specifically focused on epilepsy to train ketogenic dietitians, London, Baltimore, and there's one coming up in Buenos Aires in October. The ketogenic diet as a session at a national meeting is really starting to take off. At the European Congress on Epileptology, the very first time ever they had a ketogenic diet session. That was just held a few weeks ago. And then at the American Epilepsy Society in November, I'm chairing a session, and that's, again, really historic and the first time ever that's happened. And as well, we put together a guideline for families, for patients, for researchers about the clinical management of the ketogenic diet. We published this in 2008. We just recently did a revision of this, sort of updating the data, updating over the last 10 years what has changed in the field. And that was just published online about 2 weeks ago. So this is available. It's actually free. The open access fee was paid by the Charlie Foundation. The Carson Harris Foundation paid for that. So if you're interested, you can go look this up online and download it. So kind of what's exciting, where are we today? I think where the field is going, and again, to summarize in the time I have left, number 1 has been what can we do to make the diet safer, easier, more accessible to children out there who wish to try it. It still can be difficult, and it still can have some side effects. So what can we do to help that, knowing it works? And again, neurologists know it works. What can we do to make it easier and safer? The second is, what are the mechanisms of action? You've heard about that a lot this conference. It may be very different for epilepsy. Probably is, and so there's some interesting work going on there. The third are who should go on the ketogenic diet for epilepsy. Epilepsy is a very complicated disease, multiple syndromes, genetic, structural, inflammation that can cause it. Are there conditions that children should be put on the diet first rather than later on? And then lastly, I'll wrap up with some of the international work to bring it to developing countries. So this is the traditional initiation, what I was taught as a resident back several years ago in terms of how to start the ketogenic diet. It is traditionally started in the hospital after 2 to 4 days of teaching the family and initiating the foods in the hospital. Traditionally started with a 24-hour fasting period where overnight the child is fasted, they're on clear fluids, and then the ketogenic diet is gradually started over a few days. My dietitians are very busy creating the meals, usually at a set ratio, typically a 4-to-1 ratio of fat to carbohydrate and protein combined. That's an example from the Hopkins kitchen of a typical ketogenic breakfast brought to one of our families. Very high fat, again, about 92% calories made up of fat. What you had out in the break rooms would not be acceptable for some of our ketogenic diet patients. The families are educated daily, and the foods are weighed and measured very carefully. We see these children back very frequently with emails in between every 3 to 6 months. That's a photograph of our keto clinic, as we call it, which we have every month, where we bring the children back, neurologists, dietitians, researchers, just sort of putting everything together, trying to help these children. Most of them do stay on their medications. About 4 out of 5 stay on their medications, although we try to reduce the doses, sometimes get them off them. And then generally, at least in the pediatric world, after about 2 years, we try to get them off the diet back to what they were eating before. In most pediatric epilepsies, things do change. Some children do outgrow their seizures. And so after 2 years, we'll try to wean them off the diet and see if their seizures remain controlled. If it doesn't work, after about 3 months, we move on and try other things. And so the children come off the diet typically at 2 years. I tell them, send me a Christmas card. Sometimes they send a picture. There's actually one of my children proving that she is no longer on the ketogenic diet. And so it's great and it's nice. It's one of the nice things about pediatric epilepsy is that we can actually cure their underlying epilepsy. Maybe on their own, but maybe we can move things along quicker with dietary therapy. And so one of the questions that often comes up, this child is relatively happy. She probably doesn't want to be in the hospital. She'd rather be home. But, she has her food in front of her and she's asking us, why do I need to be here? Why does this need to be so strict? And so sort of one big thing in the field has been moving, how can we make it easier? Do we need to be so strict? Does it have to be the, quote, Hopkins protocol? And actually the good data that's out there would say, you can do things very differently and still have the same benefits for seizure control. You do not have to fast. You do not have to necessarily even admit children. You can do it as an outpatient. Some other researchers have had some very creative ideas of bringing the diet ratio up every month to gradually get the child used to it. So creative ideas, often a lot of these studies are started by dietitians, which is really great. They come up with these ideas and then we study them. We also have multiple different diets available. The classic ketogenic diet, as you can see there, second from the left, after the standard, quote, normal diet, which nobody should eat anyway. You can see there's the classic ketogenic diet, but there's some variants of it. There's the medium-chain triglyceride diet, started in the 1970s out of Chicago, the modified Atkins diet, which we created at Hopkins in around 2001, and then the low glycemic index treatment, about 2005, was created at Mass General, and they're all generally the same. As I tell most families, these are all, for the most part, high-fat, low-carbohydrate diets. Maybe the protein is a little bit different, slight variance on how we start and how we manage these children. Some slight variations on sort of maybe the mechanism. Some people think the low glycemic index treatment, which does not usually create ketosis, interestingly, may work again by a different mechanism than the ketogenic diet. In our consensus paper, we actually looked at all of the data, all the different ways to start and maintain the diet, and really tried to express to the researchers and the neurologists and dietitians that flexibility is the key. We actually were very clear that fluid and calorie restriction, there's no evidence that makes much of a difference. All of these diets seem to work. We generally encourage the ketogenic diet for under age 2, just so the dietitian can be more careful with the management, the fluid, the calories, and exactly knowing what the child is getting. And we kind of lean more towards the modified Atkins diet for teenagers and adults. Most centers still do bring children into the diet. 80%, including our center at Hopkins, we still do admit for 3 days to start the diet. But the vast majority of our consensus panel said you can do it as an outpatient if that's more appropriate for your center. And very few nowadays are fasting, but you can do it as an optional if you wish to, although not in infants. We're also a little more clear about supplements. Many of our children come in on medications for their seizures. They leave on those medications, but also many different supplements, multivitamin, calcium, vitamin D. A lot of centers are giving extra selenium now. Some good conversations I had with Steve Finney over the years. We actually use a lot of salt now, which has been very helpful for our families and our patients for getting rid of some of the side effects. Most of the supplements, though, are optional. Center by centers can make these decisions. This was table 5 in our consensus paper. So the second topic that I'll talk about briefly is, can you replace the ketogenic diet in a pill? Of course, that would be wonderful. No dietary management necessary. Stay on what you're eating. Don't change your lifestyle, but switch it to a pill. And it comes out, often these are some images captured from the press. When the press catches wind of a basic science study, usually my patients email me first, and then the press emails me second. And they say, why can't we just do this? This works in mice. Of course, let's stop the ketogenic diet and switch. It is complicated. I won't go through all the basic science. I am not a basic scientist. If you have questions, ask Stephen maybe during the break. But of course, we know the diet is complicated and changes your metabolism to burn fat instead of glucose when that's what's provided. But we also know there are multiple mechanisms at work, not just ketosis, but perhaps polyunsaturated fatty acid levels, maybe adenosine you've heard about during this meeting. All very interesting, all potentially seem to link to mitochondria. Your mitochondria seems to work better in your neurons when you're on a ketogenic diet, and maybe, that's what we think, that's why it helps epilepsy. And you can look at this, a lot of my colleagues who are clinical neurologists will look at this and go, oh my gosh, and it's so complicated and we really don't know why it works. Or you can look at it the way a lot of pharmaceutical companies are starting to look at it and say, that's very interesting. Because we have sodium channel drugs, we have calcium channel drugs, we have potassium channels. Most of these are channel drugs, and we kind of have a lot of them. But this may be a target of mechanism of action that's completely unique, almost a metabolic class of medications. And so they often hang out at the back of our conferences, and we're like, that's a pharmaceutical company. And they ask great questions often during the break, okay? And the idea being that maybe we can't completely recapitulate the diet in one pill, but if we can take one aspect of the mechanism of action, could it be helpful for some patients with epilepsy, maybe useful for patients who failed multiple medications but couldn't go on a dietary therapy? Some of these are in clinical trials. Some of these still have numbers and letters and no names yet. And so you can look at it two ways. You can say, is it a substitute? Okay, these are some of the therapies that are currently in clinical trials. Some are pretty far along, again, based on some information for the ketogenic diet. Or is it a supplement? Maybe someone's on the ketogenic diet, they've had a 90% reduction in their seizures, they're not completely seizure-free. Could you then add one of these supplements, maybe ketone esters, maybe triheptanoin, add one of these therapies, see if that would help the diet more than before? We really don't know yet. We don't know what interaction necessarily for a family, for a child on a ketogenic diet with some of these therapies could be. It could be good, but it could maybe be bad. We just don't know yet. One of the hot topics, I know it's come up several times just even today, is the microbiome. This just came out very recently that maybe this may be another mechanism of action. Some very interesting research has come out of the UCLA group, suggesting that this may be at least partially responsible by changing your gut microbiome in terms of GABA being accentuated, glutamate being dropped. Maybe that's why it helps seizures. So stay tuned on this. We also know who it works well for. This is table 1 of our consensus paper, which are conditions, specific epilepsy conditions that we know the diet seems to have a preferential benefit for. Some of these conditions I know have been talked about yesterday and a little bit this morning: GLUT1 deficiency, infantile spasms, tuberous sclerosis, where the diet seems particularly beneficial, such that maybe we should be using the diet sooner rather than later. Most neurologists know this table. It's great. They refer sooner rather than later. We get these children on the diet more rapidly. 2 hot topics here: infants. We heard from Dr. Noakes about this earlier. Is infants sort of a population that could go on dietary therapy? If you went back into the 1960s, the answer was absolutely not. This was from Sam Livingston's book on treating infants with ketogenic diets, and he said not to do it. He said that they won't make ketones. It really was not an appropriate therapy for children under 1 year of age. Fast forward 2002, Doug Nordley from Chicago said, when you look at our population, infants did fine. They did make ketones. Their seizures were improved. You shouldn't necessarily be discouraged from starting an infant with epilepsy on the ketogenic diet. And now, just 3 years ago, out of Vienna, they actually looked at children under age 2 versus children over age 2, and those under age 2 did better. So we've come like 180 degrees, and probably one of the most rapid growing population in my group are actually now infants being put on ketogenic diets for their epilepsies, and they do extremely well. Just 2 years ago, the Europeans put out their own particular guideline focusing on ketogenic diet therapy for children below the age of 2 with epilepsy. Really interesting work. On the opposite extreme, we talk about infants. Adults are probably equally fast growing. I do pediatric epilepsy. My age population stops around 18, 20 if they're really cool. And they're in college, and we talk about college stuff. But 18 is usually my cutoff, and I had a problem. So my patients would grow up. Some of them needed to stay on dietary therapy. They'd turn 18, and I had nowhere to send them. In addition, we'd get contacts from 30, 40-year-olds with epilepsy who'd say, where can I go? And we, again, had nowhere really to send them. That's really changing very quickly. Our adult epilepsy diet center started about 8 years ago. It's very busy. For every child I put on the diet, they probably put 2 adults on the diet. Initially, we thought it would be a lot of transition patients who came from my pediatric clinic. About 20% of them are like that, but about 80% are adults who just had never tried ketogenic diets before, and they have very severe epilepsy, failed multiple medications. Some of them had epilepsies that, by their nature, certainly could have been on it when they were children, but just no one had ever talked to them about it. The outcomes look good. This is actually very similar results to what we see in the pediatric world, that about a 50% response rate. Seizure-free in about 15 to 20% of that response rate. The black is the problematic area. What do we do to keep patients compliant? In the pediatric world, it's not as much of an issue for me. Parents usually can keep their child on the ketogenic diet. Adults are more willful. Adults will do what they want to do. Adults, for the most part, want to drive. And if you are 99% better but still having a seizure, you cannot drive. And so a lot of adults, that's not good enough, and they will sometimes stop the diet. Different goals and objectives. There's a lot of issues we're thinking about for adults, some very interesting research questions out there that hopefully will be answered over the next few years. How do we improve compliance? What are the ramifications if their lipid profiles are elevated? A lot of the adults with epilepsy going on modified Atkins or ketogenic diets are normal weight. They don't have metabolic syndrome or any problems, and so sometimes they do have some side effects by being on this diet. What can we do to help that? One of the big questions I think that would be wonderful if we can answer soon, and the idea of maybe a registry has been thrown around, is pregnancy. A lot of women come to us, they don't want to be on the anti-epileptic drugs because of the absolute known effects on pregnancy, and they say, we want to go on the ketogenic diet because that's safer. And we say, we really don't know that yet. We think that's probably true, but we don't know that 100%. This is just one example of a success story. The woman here closest to me in the black actually has GLUT1 deficiency, became pregnant on a ketogenic diet, delivered the baby that you see there with the beautiful red hair. Also, turned out, had GLUT1 deficiency. She has been on a ketogenic diet since before she was born, theoretically. Okay, and the natural history of GLUT1 deficiency would be to expect deficits, and you can see she's doing really, really well, and sort of a proof of principle that you can be really aggressive before even the epilepsy starts, and these children can do well. But this is just one patient. There are a few out there, but we need more information about pregnancy, for sure. And then lastly, I'll wrap up with sort of the developing world. What can we do here? It's easier said than done. I get a lot of contacts from people in Africa, Caribbean, Southeast Asia. They're interested. They know what we do. They say, can we start a ketogenic diet center here? It can be very difficult. Through the International League Against Epilepsy, we've started some early work in terms of making the diet more accessible to these parts of the world. The first step was to create a website. So if you Google ILAE and ketogenic, this comes up right away. The ILAE is the International League Against Epilepsy, probably the preeminent epilepsy, international group, and they helped us fund this website, which has information, recipes, free articles, because we know a lot of developing countries don't have subscriptions to some of the medical journals, so they can download the articles for free. We created a guideline where we sort of took our classic ketogenic diet for epilepsy guideline down a little bit and said, what's the absolute minimum that you need if perhaps you're in rural parts of Southeast Asia in terms of labs, follow-up? Do you need a dietitian? That was sort of an interesting discussion. And things are starting to move. These are just a few screenshots of some of the headlines from some of the articles that have been published really just in the last 3 years. Africa, Ghana, Morocco, South India, some really interesting studies and different ideas and ways to make the diet more accessible to those areas by, again, bringing things down a little bit. So to wrap up, again, thank you for your attention. Flexibility in the diet and supplements, I think, have made it more accessible and easy for many of our patients, not all, but certainly have helped. Metabolic-based treatments, as we're often calling them, not just necessarily all ketogenic, are now potentially a new anticonvulsant class that the pharmaceutical industry is interested in. We are certainly extending the age boundaries down to infancy and even into adulthood and trying to bring the diet around the world as much as we can over the next few years. If you want to hear more, come to Jeju Island. It should be really cool. It's supposedly an old volcano. It's a resort off the coast of Korea where the next keto meeting is going to be October 5th through 9th. And again, just like all of the speakers, I'd like to thank Jeff. Jeff and I have interacted over the years. This was actually Jeff speaking at our ketogenic conference that we had in Chicago, hosted by the Charlie Foundation many years ago. He is certainly much more of a celebrity and rock star than I am. And they were all lining up to ask him questions at the break. It was really cool to see. And so we've learned a lot from each other over the years. And this is our ketogenic diet team. It really is a team approach to make it work for these children with epilepsy. Thank you.